Hi, and welcome to Menopause Physiology and Phases. My name is Kirsten Berggren. I have a PhD in anatomy and neurobiology. I'm a family medicine nurse practitioner and a menopause certified provider. We're starting out with physiology and the phases of menopause to give a broader framework for understanding what really is happening during the menopause transition, as well as the effect of the various treatments that we'll be using. It may be a little bit more endocrinology than you really need to know, but I found for myself it was a very helpful framework to hang the rest of the knowledge and really make me feel like I had a solid understanding. I like to start with a review of the menstrual cycle. If you are a GYN or you do this all the time, feel free to skip ahead. For myself in primary care, I found this very useful, just really getting a more in-depth understanding of the role of the endogenous hormones, which gave me a foundation to understand the perimenopause and postmenopausal changes and understanding what we were doing when we were giving exogenous hormones. So to start at a very basic level, back to Bio 101, we have the gonadotropin releasing hormone secreted from the hypothalamus, which then signals the pituitary to release FSH, follicle stimulating hormone, and LH, luteinizing hormone, which then go into the circulation, and they stimulate hormone synthesis from the ovarian cells. And so what's triggered by the FSH and LH is the synthesis of 17-beta estradiol, which is our most common circulating estrogen. And this is synthesized from androgens. Then there's a positive feedback loop, which is shown on the right side with the green arrow, to the pituitary to further increase LH and FSH. But then there's negative feedback shown on the left side of inhibins and also estradiol and progesterone on the hypothalamus and the pituitary. It's complicated because the GnRH receptors in the pituitary and the FSH receptors on the target tissues up and down regulate throughout the cycle, so they don't exactly do just one thing all the time. The hormones we're talking about are generally steroid hormones. Estrogens are generally secreted by the granulosa cells of the ovarian follicle, and they promote endometrial proliferation. So this is going to be very important later. The naturally occurring forms include the 17-beta estradiol, estrone, and estriol. And as you can see from the illustration on the top right, these interchange fairly readily in the body through various metabolic pathways. Progesterone is secreted by the corpus luteum after ovulation, and what it does is a stabilization and vascularization of the endometrium. So it really converts the endometrium into a secretory tissue by increasing the circulation there. Withdrawal of progesterone leads to a sloughing off of the endometrium because we've lost that stabilization. Another hormone that we'll be talking about as the course goes on is DHEA. It's a precursor of estrogen and testosterone secreted by the adrenal gland, and it's converted to steroid hormones at the target tissues. So sometimes those levels can be important. I've put this diagram in just to show the interconversion of a lot of these hormones. They are all cholesterol based. And in the ovaries and adrenal glands, there's conversion from DHEA through various pathways to testosterone and then to estrone and estradiol, which then are active in the peripheral tissues. So really basic menstrual cycle 101. So the first phase is the follicular phase. This is from day 1 to approximately day 14, but this has some variability. During this phase, at the beginning of it, you can see the green line, that's the FSH, has a small surge, and that stimulates a cohort of follicles to mature. And then out of this cohort, you have a dominant follicle that then secretes estrogen. The estrogen provides feedback, which then lowers that FSH level from the pituitary. And during this time, you get the growth and proliferation of that endometrial lining of the uterus in preparation for the implantation of the fertilized ova. Towards the end of the follicular phase, the estrogen feedback then increases FSH, so it turns into a positive feedback loop, and you get this large LH and FSH surge from the pituitary. So during ovulation, you have this LH and FSH surge, which then causes the release of the oocyte from the follicle And at that point, the estrogen levels drop off fairly precipitously, and the corpus luteum, which is the follicle, starts to take over production of progesterone, which then rises fairly steeply. So during the luteal phase, it's called secretory because that uterine lining becomes a secretory tissue. So there's proliferation of glands and blood vessels throughout that endometrium. And in every diagram I find, it looks like the endometrium continues to thicken. That doesn't really happen. And here's a diagram from a study that looked at endometrial thickness measured every single day through the cycle, with the line in the middle being the day of ovulation, and the fainter line on the bottom is actually the normals. This is an experiment that had some other experimental conditions put on it, but that's not really important. What it shows, though, is that endometrium maintains a pretty stable thickness, but it does change in nature to a much more stable secretory tissue rather than the continuing proliferation that we see under the influence of estrogen. So the progesterone provides a negative feedback loop back to the pituitary, and then the FSH and LH levels will continue to drop. I found this really great in-depth review online if you want to refresh your knowledge of the menstrual cycle a little bit more. So with that foundation, I think this is really helpful to going forward and talking about the hormone changes that happen during menopause. And so the objectives of this section are to understand the STRA plus 10 staging framework, understand the main clinical features of each stage from the menopause transition through menopause and postmenopause. And really, we're going to be primarily looking at what's happening with the menstrual cycle and what's happening with the hormones. And then we'll go on in later lectures to really talk about the systemic symptoms and how this is affecting women on a day-to-day basis. So menopause itself is just that last menstrual cycle, and it's retroactively identified after a year of amenorrhea. Reproductive aging involves the loss of follicles across the lifespan of a woman, and these are typically lost through ovulation, but mostly through atresia. We actually have all of the follicles that we'll ever need in utero, and the peak number is about 6 or 7 million follicles at about 7 months of gestation, but the atresia starts as soon as the follicles are there. And so by the time a woman is born, a female baby is born, there'll be about 1 million follicles. By the time she hits puberty, only half that much, about 500,000. And at menopause, women can still have 300, even 1,000 remaining follicles, but because of the loss of that follicular reserve, there aren't enough hormones being generated to continue to support menstruation and fertility. So a little bit about this STRA plus 10 staging was developed in 2001. The principal criteria is not age, but where you are with your menstrual cycle. And that's used to gauge what stage that you're at. So it's irrespective of age. You can be, at stage 0 at 45 or 53, and it's still the same stage 0. The limitation was that it required a menstrual cycle to know where you were. And so this was redone in 2011, where the endocrine markers were added. And these are used as markers of normal reproductive aging, but can also be used in other situations, such as diagnosing primary ovarian insufficiency. It can be used in the setting of irregular menstrual periods, hysterectomy, endometrial ablation, IUD, any of the reasons that a woman wouldn't be having a normal menstrual cycle. There are still some limitations, but overall, this is the framework that's being used. And I find even if you don't need to know the stages, it's just sort of helpful to walk through the different phases. So I wanted to talk a little bit about 2 more hormones that we haven't covered as part of the menstrual cycle. The anti-Mullerian hormone, called AMH, is an indicator of ovarian reserve because it's synthesized by the granulosa cells in the primary follicles. So as that number goes down, the AMH levels will also drop. This varies across the menstrual cycle by about 10%, and there's a lot of variability between women, but this can be an early predictor, and the graph at the bottom here shows that once the AMH levels are below about 0.12 nanograms per deciliter, so it's very low just to start with, we're looking at about 2 years to the last menstrual cycle. When the AMH levels are higher, it's very difficult to predict how long it will be till that last cycle. There's very rarely a need for this, but it is one of the things that's shown in the stages. Another hormone that we'll be tracking are inhibins. There's inhibin A and inhibin B. These are, again, indicators of ovarian reserve. They're also synthesized by the granulosa cells. They also have varying levels across the menstrual cycle, but the dropping levels of inhibin allow for an elevation in FSH because FSH is inhibited by the inhibin hormones that are synthesized by the follicular cells. So the number of follicular cells determines the level of FSH inversely. As that number goes down, there's less inhibin, and so then the FSH levels can rise, and we'll see a lot of the results of that. And in the graph, what you see is the dashed lines at the bottom left show the drop in inhibin A and inhibin B, and the black line that goes the highest, that's the coincident elevation in the levels of FSH. So if we look at the staging, we have 3 major groupings. There's the reproductive years with early, peak, and late. The menopause transition, which is the time just before that final menstrual period. There's the final menstrual period itself, and then post-menopause. And the way that the numbering works is that the final menstrual period is designated as stage 0. Stages before that are in negative numbers. Stages after that are in positive numbers. And here is the published STRAW plus 10 staging criteria. We'll go through this and break it down literally and look at it piece by piece. So the reproductive phase starts with the first menstrual cycle. This is considered stage -5. That's the early reproductive phase. That's when periods are still variable. Once they become regular, then we consider somebody to be in their peak reproductive period, which is stage -4. And during this time, we really don't see a lot of changes in these endocrine markers. When we get into the late reproductive phase, this is called stage -3, we start to see some changes. So the late reproductive phase has an early and a late portion to it. During the early portion, which is -3b, the menstrual cycles are typically regular. The FSH remains low, and there are endocrine changes occurring prior to the time that we actually see any changes in the menstrual cycle. Looking at things, you would see a lower level of AMH and the antral follicular count, which is determined by ultrasound. These are both dropping. In the later part of the late reproductive phase, we start to see some subtle changes in the menstrual cycle with an increased frequency of shorter cycles, and we'll talk a little bit about how that happens, along with some variation in the FSH levels with, again, lower AMH, inhibin, and AFC, the antral follicular count. So now we've gotten to the menopause transition. So this is the period that we also call perimenopause. The Menopause Society has some preference for using the word menopause transition rather than perimenopause, but perimenopause is certainly what you will see used in popular conversation and what women will come to you complaining about. So the early menopause transition is called stage -2, and this has a highly variable duration. It can last up to 7 years. During this time, we see persistent changes in the menstrual cycle length, and this is defined by changes of more than 7 days and occasional skipped cycles. At this time, the FSH is starting to go up. AMH and inhibin B and the antral follicular count are all dropping. And as we talked about before, those low inhibin levels release the inhibition on FSH, and that's why that's going up. The AMH also inhibits follicular growth, and the release of that inhibition makes more follicles available. So we have more follicles available, and higher FSH stimulating those follicles. So we end up with more rapid follicular growth, which seems counterintuitive, but we start to get shorter cycles and what are called loop cycles, luteal out of phase cycles. And we'll talk about how those work. When you start to see these shorter cycles, it's the follicular phase that's shortening. The luteal phase is very constant at about 14 days. And so because of the shortening of the follicular phase, the luteal phase takes up more of the time. So we call that a luteal phase dominance. And during this time, a lot of women will complain of worse severity of premenstrual symptoms. So a loop cycle, this is the classic diagram of a loop cycle. And remember that we're in an atmosphere of rising FSH levels. So what you'll see is if you look at the bottom of this diagram, you'll see the number 1. That's the initial recruitment wave of a group of follicles recruited by that FSH elevation. And these follicles then will start to secrete estrogen. So the estrogen levels go up, as is indicated by that bold line. But then, because the FSH levels are high and the inhibition of the AMH on the follicles is low, you can get a secondary recruitment wave. So that's indicated by the number 2 on the bottom of this slide. And then at that time, you have a superimposed secretion of estrogen by that second primary follicle or second dominant follicle. And then what ends up happening is that you can get these 2 menses in a very close sequence, one right after the other. Loop cycles are fairly common. They happen in about a quarter of the cycles in stage negative 2A, about a third of cycles in negative 2B. So those are our early menopause transition phases. And this is just what I showed in the picture in words. Elevated FSH recruits another follicle during the luteal phase. There's superimposed follicular estrogen elevations. There's a fall in the luteal progesterone. And if these surges happen within 5 days of each other, the second cycle will then be unusually short. That second cycle will be less than 21 days. If there's not ovulation, then the FSH and estradiol levels drop, and then the next cycle is longer than average. So you get short cycles, long cycles, missed cycles, kind of all over the place. And when you think about it, this is the hormonal roller coaster that is absolutely miserable for so many women symptomatically, because it's not that your estrogen just takes this nice gradual decline. It goes up, it drops, it goes up, it drops. And that's the part that really makes the symptoms unbearable for a lot of women. So because of these cycles, you can get actually elevated estrogen during the perimenopause period. And this can result in estrogen-dominant symptoms. So you may get breast tenderness, migraine, heavy periods, growth of fibroids, endometrial hyperplasia. And then there's additional conversion of androgen to estrogen through aromatization that happens more with higher body weight, and it also increases with age. So your tissues are being exposed to these higher levels of estrogen, which carries its own risk factors. A longer menopause transition increases this exposure, which is cumulative, and the unopposed estrogen, as the progesterone drops, can cause an increased risk in reproductive cancers. So something to be aware of when your patients have a very long menopause transition. So I apologize, it's a little bit of a busy slide, but this is looking at late reproductive aged females, which are shown in the yellow-orange, and younger females shown in blue. And what we see when we compare is that the top right graph is the FSH levels. So those are consistently elevated throughout the cycle in the older reproductive age women. And again, they're all premenopausal. And if you look at the estrogen levels, which is the middle graph on the left, that shows those consistently elevated estrogen levels. But then if you look at the middle on the right, you can see the yellow curve is much, much lower, and that's the progesterone levels throughout the cycle. So the last phase of the menopause transition is stage -1. So this is the late menopause transition. Typically lasts about 1 to 3 years. And so if you think about that, that 1 to 3 years plus the however many up to 7 of the early menopause transition, we can be looking at 10 years of a menopause transition. Menopause is normal after age 45 and is not really considered pathological until earlier than age 40. And so if you have a woman in her late 30s who's complaining about symptoms that sound like menopause, don't tell her that she's too young. 35 is not really too young to be starting to show some of these symptoms. So it's just something to have on your radar and be aware of. The duration of the menopause transition can really be quite long. This late menopause transition is defined by intervals of amenorrhea of at least 60 days. So you're now having more anovulatory cycles. Because you're having anovulatory cycles, you're not recruiting that dominant follicle, which is secreting the estrogen. So the estrogen production is dropping. And now we start to see symptoms from estrogen deficiency with vasomotor symptoms. So hot flashes, night sweats really predominating. Progesterone production decreases. FSH levels might have a little spike up to, 25 or higher units per liter, but it's highly variable, can go up and down. So if a woman is still having periods, I don't put a lot of stock in a single elevated FSH. FSH levels can also be completely normal during this time. And we're continuing to see the drop in the AMH, inhibin levels, and the follicular count. Stage 0, as I mentioned, that's just that last period. Median age is, depending on who's doing the research, 50.5 to 52. 90% of women will reach menopause by the age of 55. Early menopause is defined as before age 45, and premature menopause or premature ovarian insufficiency is defined as before age 40. Primary ovarian insufficiency. We used to call this premature ovarian failure, but we don't like to put the word failure in there. So primary ovarian insufficiency. And in these discussions, we talk about early menopause being before age 45. That doesn't mean the early menopause transition or the late menopause transition. So just, be mindful of what early and late you're talking about in these stages. Demographics, the number of U.S. women over age 50 is over 60 million at this time, and it's expected to be 90 million by the year 2060. And 60% of women are expected to live into their 80s. So with this increased life expectancy, women will be spending up to 40% of their lives in menopause, which is, it's something. We really need to be paying attention to this. That's as much as a quarter or up to a half of your patient population, depending on the age that you tend to treat. All right, so now we look at the postmenopausal stages. During the first 2 years after that last menstrual period, we have stages +1 and +1A and +1B. Those are just divided arbitrarily into 1-year intervals. The FSH levels continue to increase, estradiol continues to decrease, so this is still a period of hormonal variability. And it's really the variability being yanked around by those hormones that can cause a lot of the really intolerable symptoms. You can still have normal FSH levels. You can have variable estrogen production for that first year, even with amenorrhea. And then the progesterone production is essentially stopped because you're not having any ovulatory cycles. Vasomotor symptoms are the most prevalent in these first 2 postmenopausal years, but as we'll talk about in the lecture on vasomotor symptoms, they can start at the first signs of that menopause transition, and they can persist as long as the rest of the woman's life. But again, most prevalent in these first 2 postmenopausal years. And then the official end of what we call the perimenopause is at the end of stage +1A, so at the end of that first year after the final menstrual period. The postmenopausal stage 1C, again, these are sort of arbitrarily just assigned to years. So these are 3 to 6 years after the final menstrual period. FSH levels now are consistently high. You'll be seeing levels 60, 70, 80 when you're testing. And that tends to start about 4 years after the final menstrual period. But again, those FSH levels can be variable, and we don't really need to be looking at them unless we're looking at changing somebody's therapy depending on whether she's pre or postmenopausal. So routine screening for these hormones is not indicated. And I really, really want to emphasize that. We've been talking a lot about these hormone levels, and that's something that I think is important for our understanding of how these things work. But as we'll talk about when we're diagnosing menopausal symptoms, when we're treating women, the hormone testing is not an important part of it, and a lot of that is because of the variability. Those hormone levels are not always very informative. In these later stages, the estradiol levels stabilize at a lower level, and so you're not getting as many symptoms that are related to the withdrawal of estrogen. So as we move into these last stages, this postmenopausal stage +2, which is basically 5 or 8 years after that last menstrual period and then throughout the lifespan, the estrogen depletion symptoms are the ones that really predominate. So urogenital symptoms are going to be number one. Skin changes, loss of collagen, hair loss. And these are primarily related to the estrogen depletion, but then we'll also see changes that are just related to somatic aging. So there are changes that are going to be the same with men and women, and those are our somatic aging changes. In the ovaries after menopause, intact ovaries will continue to produce testosterone and its precursors up to about age 70 at a pretty steady state level, and then those levels will decline. You will see lower testosterone levels after age 65 associated with various factors, including a lower BMI, being white, taking estrogen, surgical menopause, steroid use. But as we'll discuss when we talk about sexual dysfunction, there's very little correlation between circulating testosterone levels and what's actually going on functionally. I just wanted to put in a quick note about estrogen and obesity. We're going to have an entire other lecture on weight management and weight gain during menopause and lots of interesting stuff about that. But I just want to say in this context that when women are obese or overweight, they tend to have lower estrogen levels premenopausally, but higher estrogen levels postmenopausally. And this is due to the aromatization of testosterone and other androgen precursors into estrogen in the adipose tissues. And you may find that some of your overweight or obese patients actually have an easier transition because there's not as abrupt of a withdrawal, as abrupt of a change in the estrogen levels. There are a couple other things that are different with obesity. The inhibin levels are lower in premenopausal obese women. But then again, this is also reversed in the late transition stage. And the FSH levels also tend to be lower in postmenopausal obese women compared to non-obese women, so you may not be able to use that FSH as diagnostically. So thank you for bearing with me through some discussion, deep dive into the hormones. Hopefully that gives you a really good foundation for understanding the rest of the lectures. Up next, we'll be talking about menopause pathology, including the primary ovarian insufficiency and abnormal uterine bleeding and diagnostic tests that you'll want to be looking at. We'll be talking extensively about menopause symptoms, not just vasomotor symptoms and GSM, which is the genitourinary syndrome of menopause, but also mood, weight, sleep, musculoskeletal concerns, all the good stuff, as well as other midlife health concerns and how they relate to menopause and hormone therapy. And then we'll be taking a deep dive into menopause treatment, including risk-benefit analysis of using hormone therapy, as well as practical step-by-step guides for exactly how to prescribe. So we're happy to have you along with us for the ride. I have included a reference slide if there it's tiny, but this will also be available in our notes if you want to look any deeper into some of this research. Thank you.